is a very dynamic field where a lot of things are changing in the relapsed refractory space, and some of those treatments are now being added to upfront treatment as well, mainly in the clinical trials. In the frontline treatment of diffuse large B-cell lymphoma for over 20 years, the standard has been chemoimmunotherapy, with R-CHOP being the most commonly used. More recently, there was a study called POLARIX, which showed that addition of polatuzumab vedotin to R-CHOP was superior to R-CHOP in terms of the progression-free survival, but not an overall survival. What's interesting about the study in a subset analysis, we actually do see that patients with ABC subtype of diffuse large B-cell lymphoma, which is a more aggressive typically subtype, tend to benefit the most from addition of polatuzumab vedotin. We don't necessarily see the same benefit in GCB patients, although those are just subset analysis. Having said so, it's an important study, and a lot of groups switched to using Pola-CHIP as the initial induction therapy in large cell lymphoma. Some groups use it to all comers, just as in a study. Some groups, like ours, tend to focus on non-GCB or ABC subtype of diffuse large B-cell lymphoma. Despite this progress, unfortunately, about 40% of the patients will relapse with diffuse large B-cell lymphoma. It typically happens early, within the first year or two, and those patients still have a poor outcome, although huge progress has been made in the management of those patients. It's really beyond this interview to even describe this progress and the sequencing of therapy, because so much has changed. But one of the major changes which we see is this evolution of cellular therapies. So patients with early relapse, 12 months, within 12 months, we typically use CAR T-cell therapy in the second line if patients are eligible for that. And for relapses afterwards in the third line, or in the second line for patients who are not eligible for CAR T-cell therapy, there are a number of novel agents, including monoclonal antibodies, antibody-drug conjugates, and now we also have something which is called bispecific, what I'm calling bispecific revolution. So there's a T-cell engagers and bispecific antibodies, which are really very active and working across different lines of therapy and really rapidly changing this field.